Tēnā koutou, tēnā koutou katoa. As Sway mentioned, I'm Laurelie. I'm here to guide you through the evening. Welcome all to this, our second and final public talk at the University of Otago, Christchurch for 2024. Last week it was women's midlife health, this week men's, and we've got another great audience tonight. Thank you all for coming out. As Sway said, in such a cold day, I looked around this morning and I doubted we'd get anyone turning up. It was looking so miserable, but it's brightened, and so that's great. Whaia te mātauranga he oranga mō koutou. Seek knowledge for the sake of your well-being. And that's sort of why we're here tonight, to seek knowledge, to sort out the myths from the truths, and to come out just knowing the truths, really. For many men, the 40s and the 50s are the first time many get the sense they're getting older. It may well be you play a game of sport and then you get up and you can't move the next day. Or a normal night out sees you very exhausted, and it creeps up. It's also at a time when a lot of men are experiencing peak stresses at work. Like women, they're juggling the needs of ageing parents and growing children. And also too, mental health is another issue. Some are finding it difficult to get a sense of self. Friendships are harder to maintain. In fact, I read a study today that suggests that the midlife are the loneliest years of a man's life of all. And I thought it was the older age group, but apparently midlife, there are concerns for that. On top of that, we've got the traditional Kiwi blokes in New Zealand, don't we? You know, the cultural stoicism, the she'll be right. And I suppose some men don't have GPs, or they don't have a good relationship with their GPs. Clearly, the men here tonight do. That's why you're here, because you're interested in your health. And also, a lot of men, of course, traditionally wait till it's a little bit late to go to see the doctor on some issues. A little bit of a, you know, don't worry about it, it'll go away tomorrow sort of thing. And also, there's a lot of research, and, well, I say research in inverted commas, stuff on the internet which can lead you astray. Dr. Google can have you awake all night worrying, and also you being sold things the whole time. You click on something and an algorithm will send you everything you did or didn't want to know on that particular diet, that health regime, or that pill or potion. So, as I said before, the myths from the truth, that's what our speakers here tonight. Let me introduce them. We've got Professor Ben Hudson, Professor Mark Richards, Associate Professor Katie Douglas, and Dr. Michael Hlavac. And I'd like to thank them in advance very much for sparing their time. They're very busy clinicians and researchers to be here with us tonight. Very quickly, health and safety message. If anything happens, don't come down here, head up there and head out those two doors. This is basement level, that's ground level, so head out that way, that's where you need to go. I'm going to introduce and give a quick bio on each of the speakers before they get up and talk this evening. I'm starting with Professor Ben Hudson. Ben's a senior lecturer and head of our campus's Department of General Practice. He's also the convener for the Training Intern General Practice Attachment for aspiring young doctors who've decided to become GPs, and don't we need more of them. Ben trained in medicine at Newcastle upon Tyne in the UK and completed his GP training in the northeast of England. He's worked as a GP in Littleton since 2005. His research interests, apart from being a general practitioner, are in pain management and osteoarthritis and risk communication, which is exactly what we want to hear from him tonight. In addition to his academic and clinical roles, Ben's now medical director at Pegasus Health, which supports the largest grouping of GPs in Canterbury, which in turn look after over 450,000 Cantabrians and their health. He currently holds advisory positions with the Health Research Council, Te Whatu Ora, the Ministry of Health, and the National Heart Foundation. And he previously chaired the Canterbury faculty of the Royal New Zealand College of General Practitioners, was a member of the college's National Advisory Committee, and has been an expert advisor to Pharmac. Welcome, Ben.
Well, thank you very much, Laurelie, and you seem to know more about me than I know about myself, which is somewhat scary. Also, thank you for the promotion to Professor. I'll speak to Suze about my pay rise later on. Well, kia ora koutou, everybody, and I don't need to tell you now I'm a GP, and I've been at my practice for, I suppose that's nearly 20 years. And over that time, men's health has become something of, I was going to say a love, but at least an interest of mine, as I've been for almost all those 20 years the only male GP, in fact the only male member of staff other than for about 2 years where we had another male doctor. So I sometimes feel like I spend a lot of my day talking to middle-aged men and about middle-aged men's health. And yet, there's definitely a perception that this is a kind of a difficult area. This is nicely illustrated by these somewhat apocalyptic headlines here, that men would prefer to do chores than talk about their health. They won't come to see the doctor. They won't do what they're told to make themselves more healthy. And I think this reluctance is somewhat in part due to the fact that we kind of know what we should be doing already. And these are all the usual things. These are the best things that you can do. And you won't be able to see, won't be surprised to see this list. You should stop smoking if you smoke. You should be more physically active. You should eat a healthy diet and drink less alcohol. The trouble is, these are all quite difficult to do for most of us. One memorable patient, when advised to do all of these things, replied that he was somewhat reluctant to believe that any of these things would make him live any longer, but he was pretty confident it would feel like he did if he followed that advice. Consequently, some of these, or many of these consultations go a little bit like this. This is a fairly common situation, certainly in my practice, and I'm sure for many of my colleagues. I don't know if you recognize Andy Capp here. He was, or I think still is, a favorite of, I think it's the Daily Mirror, one of the British tabloids. He's a sort of voice of common sense, working man, everyman type character. So I thought what we might do over the next few minutes is assume that everyone's going to do all the first best things already, because we know that they're the best things to do, and think a little bit about the second best things and how you might work your way through some of those things that you might be offered in a way that will allow you to make a rational, informed decision about which of them, if any, you want to do. And the list of second best things is long. It ranges from the sensible and evidence-based, statins here to reduce the risk of heart disease and stroke, or screening to reduce the risk of some diseases, to reduce the risk of dying of some specific diseases, to the less credible, dietary supplements. This is a particular favorite, not of mine, but of some men I know. Libido support with triple strength horny goat weed as the active ingredient. To the ridiculous testicular tanning, whole body vibration, and this is worse than ridiculous. This is kind of dubiously ethically, I think, that some wealthy tech bros in Silicon Valley are apparently using transfusions of blood products from young, healthy men in a sort of pursuit of eternal youth. So I thought it'd be good to think about how you might decide which of these are worth doing. And of course, it comes down to a balance of benefit and cost. On the one hand, does this work? If it does it work enough to make it worthwhile for you? Is it addressing something that's important for you? Balanced against what are the costs? And they might be side effects, financial costs, time that's taken to engage in some sort of intervention. Now, to answer the first question, does it work? You should expect, I think, that if someone reputable is offering you an intervention to improve your health, that it should have been tested in a good quality trial and shown conclusively to have some benefits. Well, that's not always the case, sadly. An example of this over the last few decades has been the promotion of vitamin supplementation based on the observation that people with higher levels of some vitamins are at lower risk of certain diseases. A really good example of this has been the enthusiasm that we saw probably over the last couple of decades for vitamin D. This was largely based on a number of studies that correlated levels of vitamin D in people with their risk of a range of diseases, and showed that people with high levels of vitamin D tended to have lower rates of a whole range of diseases, even a lower risk of death. Now, that sounds really encouraging, and on the basis of that, many people were recommended, and I think still do, take vitamin D supplements. However, when you subject vitamin D to a much more rigorous assessment of its efficacy, and that's with a randomized clinical trial where you take a large group of people and randomly allocate them either to take vitamin D or a placebo, and collect data on the number of events that happen, the results are rather disappointing. This was a really neat paper in the BMJ that summarized observational studies, findings, and compared them with trial findings. Now, assuming that we've satisfied our first question, that there is trial data to support an effect, and that the intervention is genuinely useful, you should be then asking, how big is this effect? And if you're given an answer like this, drug X will reduce the risk of cancer or heart attacks or strokes by 20%, you should feel very free to ask the obvious question, 20% of what? Now, I think it's very unlikely that anybody here would buy a car based simply on the fact that they've been offered a 20% discount on its price. You're likely to be much more influenced about your decision to buy the car based on whether you're talking about a 20-year-old Toyota or a brand new Bentley. Just being given a 20% discount is unlikely to give you enough information to make a decision to commit yourself to the vehicle. And just as you'd like to see the cash price in real numbers for the car, you should expect the same if you're offered some sort of medication or other intervention to reduce your risk of some health event. As an example of this, we can think about the use of statins. Now, statins have been subjected to a large number of trials that have consistently shown that they're effective in reducing the risk of heart attack, stroke, and death. We're back to Andy Capp here, and he's been found to have high cholesterol, and his GP, not unreasonably, is suggesting that he should think about taking a statin. Andy, of course, makes a wise, or asks a wise question, how big a difference will it make? His GP could say, and it would be mathematically true, it'll reduce your risk of heart attack, stroke, whatever, by about 25%. But it'd be much more useful if he could convey that to Andy in some real numbers. And to do that, what we'd like to know is how at risk is Andy of those conditions, first of all without treatment, and then with treatment. Well, we can think about two different scenarios. First of all, we've got fit Andy. He's 55, he's an ex-smoker, he's got diabetes, but it's well controlled, and he's on some treatment for blood pressure, and that's doing a good job. And we can calculate that Andy's risk of heart disease over the next 5 years is around 7%. If we treat Andy with a statin, we'd reduce his risk to about 5%, so a 2 percentage point reduction in his risk of those conditions. If Andy was a bit older, so 65, and a smoker, and he had high blood pressure that wasn't treated, then for the same level of cholesterol, his risk is going to be significantly higher. So he's got a 22% risk of a range of cardiac problems over the next 5 years. And consequently, the reduction in his risk that we would achieve with a statin is commensurately higher. So he gets a 5 percentage point reduction in risk to around a 17% risk on treatment. Now, this approach to thinking about risk and benefit can be applied just as much to a question of screening as to a question of medication. And of course, in midlife, you start to be offered a range of screening programs. This is Sir Muir Gray, who's an eminent Scottish public health physician and a doyen of screening. And he summarized really succinctly a way of thinking about the benefits and harms of screening. And he asks 3 questions to do this, or gives 3 suggestions to do this. All screening programs do harm. Some do good as well as harm. And of these, some do more good than harm at reasonable cost. Now, that way of thinking is framed about screening at a population level, but you can apply the same principles to making an individual decision. And as an example, we can think about screening for prostate cancer. This graphic it illustrates 1,000 men. Each little square is 1 man. And what I'd like you to do is consider each of these 1,000 men, and we're going to follow them for a period of 11 years. The little green squares in the bottom left-hand corner are the around 5 men who you'd expect to die from prostate cancer over an 11-year period if we don't screen. If we screen all those 1,000 men and follow them over 1,000 years, over 1,000 years, the outcome's not so good. If you screen all the 1,000 men over an 11-year period, we'd drop the number who we would expect to die from prostate cancer from around 5 deaths to around 4 deaths. So a reduction of 1 death for every 1,000 men screened over an 11-year period. Now you could, arithmetically, correctly say, we'll give you a 20% risk reduction. Of course that's true, but it's rather less meaningful. You'll also want to consider the harms of screening, just as you would of any treatment. And with prostate cancer, we can make an attempt to quantify them, the main ones being overdiagnosis, the detection of disease that would never have caused problems had we not found it, and side effects of the treatments. Now, whether in Sir Muir's words, prostate cancer screening does more good than harm at reasonable cost, will be a decision that's different for every man. Every man will balance those benefits and harms in a different way, and we shouldn't be, I think, uncomfortable about the fact that people will reach different decisions about whether or not to screen when presented with this information. So, in closing, I'd like to express a hope that next time you get dragged to your GP by your long-suffering wife or partner, and I'm sure neither of you really look like Andy and Flo Cap, you feel confident to ask those 3 questions about any offer of treatment. And of course, in the meantime, whatever else you decide to do, keep doing the best things. Thanks very much.
Thank you very much again, Ben. Professor Mark Richards now. Now, he is a world-leading cardiovascular researcher and he's a pioneer in the field of cardiac research. His work has changed the way heart failure is diagnosed and treated not just in New Zealand but around the globe. He graduated in medicine from Otago University and has since earned Otago Doctor of Medicine and Doctor of Science degrees as well. And as well as being a cardiologist of long standing here in Canterbury, he's the director of the hugely respected Christchurch Heart Institute, which sits within this campus's Department of Medicine. He's a joint professor too at both the University of Otago and the University of Singapore. For more than 30 years, the Christchurch Heart Institute, or the CHI, has been recognised as a world leader in the development of diagnostic tests and treatments and the understanding of risk factors for heart disease. Of particular note was its discovery in 1995 of a hormone produced when the heart's under pressure. And the hormone blood test they discovered from that is now the most widely used test for heart failure globally. The group and its now commercial arm, Upstream Medical Technologies, has developed several sophisticated blood tests which are being used internationally in diagnosing heart failure and assessing how intensively patients need to be treated and with what drugs. He and his team have also been working with research centres around the world to define the best use of the heart marker troponin to determine which patients can be safely sent home from the emergency department when they present with heart issues. Mark's a worthy recipient of numerous honours and awards, including the University of Otago's highest research honour, the Distinguished Research Medal. He's published more than 300 research papers, and in recent years his research has focused on the characteristics of heart failure patients from different countries and ethnicities. Welcome, Mark.
Thanks, Laurelie, and I want to make it clear that all of those things I did entirely by myself. Thanks again for coming out on a cold evening, everybody. My brief is to tell you whether or not you might be a walking heart attack. Well, if this chat reminds you of yourself, you may be at some possible risk. There are about 17,000 admissions to hospitals in New Zealand every year for people with heart attacks. 5,000 people per year die of this condition. That's roughly, I think, 100 a week or thereabouts. And even if you survive your first episode, over the next year there's quite a high chance, 1 in 6 chance, that you will have another event which could be fatal or non-fatal. So what is the problem? Well, the heart's a complicated beast. It's a strong muscle that provides circulation to every tissue in your body all day long, every day. It never takes a break. If it does, then that's bad. That has a blood supply, and this is where a lot of the problem arises. These vessels course over the surface of the heart and provide it with oxygen and blood. They fuel the heart. It's got a wiring system, so everything works in the correct order. It's got valves, so blood flows in the correct direction. But really, the main reason for heart attacks resides within these blood vessels, which can become narrowed. And then, if circumstances are unfortunate, the narrowings can then sort of break or crack a bit, rupture, and then the vessels clot. Then that bit of heart is subject to threat and may even be killed. And complications include bad things. That's called ischemic heart disease, and the World Health Organization scored the burden of disease in the world in 1990 and said that coronary heart disease or ischemic heart disease was about number 5, but by 2020 it had risen to number 1 and it's stayed there ever since. However, that's the world, and it makes a big difference where you are in the world. It's very good to be a Kiwi. So the peak threat to middle-aged New Zealand males, these are 35 to 65-year-olds, was way back just before about 1970. And over the last 50 years, this is what's happened to our rate of coronary heart disease death in this country, from about 460 per 100,000 men in that age group down to about 60, an 85% drop over that period of time. So it's not all bad, and stay in New Zealand is probably a good piece of advice. Don't go to Russia. This is Russia. That's the New Zealand pattern. Russia doesn't know whether it's peaked yet or not. It keeps changing its mind over recent times, and its current rate is still 5 times in Russian men as it is in New Zealand men. In fact, the rate for New Zealand men is about the same as Russian women, because women always do better, and that's probably the only thing in common that New Zealand men and Russian women actually have, I suspect. So what are the things that make you predisposed for these vessels to get narrowed and then to block? Well, there are things that you can do not much about, whether you're a man or a woman, how old you are or how much aging you're going through, and your family background. You can't do much about those. There are things that you can attack with some degree of success. Your weight, amount of exercise, your blood pressure, whether you smoke or not, what your cholesterol's like. Ben's told us a bit about cholesterol, presence or absence of diabetes. And then, very importantly, is a thing called unknowns, because I hate to tell you this, but around about 15% of people who have heart attacks don't have any of those background things in red, and we don't really know why. And that's something of the focus of research around the world to this day. So what happens if you go along to your GP, go to Ben when you're age 45, and you want to know, are you in good shape? Do the next 5 or 10 years look pretty safe, or is there a bit of a threat on the horizon? And what we used to do is use these colour charts. We now use sort of algorithms and computers, and it's all a black box. But I like these charts because you can kind of understand them easily. There's a set of charts for men, and there's a set of charts for women. I'm just seeing if I can make a dot appear. Seems I can't. And you can divide them into whether they are smokers or non-smokers, have diabetes or not, and what their cholesterol is and what their blood pressure is. And you can see within that red surround that we've put up there, if you look down towards the lower left-hand side, that's a man who has normal blood pressure in that age group, lower end 45. He has normal cholesterol levels, doesn't smoke, not diabetic. And if you look at the colour of his square and then refer that to the key in the middle of the slide, you'll see that person has somewhere between 2.5% to 5% chance of a major cardiac event or cardiovascular event sometime in the next 5 years. And that might be a heart attack, fatal or non-fatal, a stroke, or some other arterial catastrophe. So that's some degree of handle on how to get an idea of your own personal risk. And those are all things that GPs can conduct and do routinely all the time. There's some good news for New Zealand in that these colour charts and these equations were originally based on United States data. And it turns out that after you look at a few 100,000 Kiwis and see what their risks really are over about a 10-year period, we're actually a lot better off. Another reason to stay in New Zealand. Something like 40 or 60% overestimate of risk if you use the American data compared with using New Zealand data for New Zealand people. What can you do? High blood pressure, very prevalent, 1 in 5 Kiwis. It's a silent condition, often not apparent until you have your stroke or have your heart attack. Not all of it is detected. That which is detected, not all is treated. That which is treated, not all is controlled. There are, however, on the bright side, many treatments available, and they do work. The problem is they take time and persistence, both by the patient and by the doctor, because often you need more than one medication, you need more sustained efforts at various lifestyle factors. But you can have these things done, and they are available, and they do work. And if you do control your blood pressure, you definitely reduce your risk of heart failure in particular, and coronary events as well. So don't give up on it. If you've got blood pressure tablets, try and make sure that they're enough, and get your blood pressure checked regularly. What about smoking? Well, smoking in New Zealand is also quite a good news story. You see that from 2022-23, only 6.8% of adult New Zealanders smoke. And that compares with about something less than 20 years ago where we had 16% smoking. Even better news, in young adults, 18 to 24-year-olds, now less than 4% smoke, whereas back in about 2005 and 6, 25%, 1 in 4 of those young adult people were smoking. There are tools to help people stop smoking, and our primary caregivers do understand these tools, can offer them. I'm pleased to say that my grown-up son and daughter have recently successfully stopped smoking with the aid of these techniques. So you can stop, and if you can, you really should. One of the most key things you can do if you're unfortunate enough to have a heart attack, having been a smoker, is to stop smoking. That cuts your risk of a further heart attack by 50%. It's actually more important than almost anything else you can do, including coronary artery bypass graft surgery. Obesity, we all know we're supposed to move more and eat less, easy to say, very hard to do. And the history of obesity management programs for the last 30, 40 years has been one of consistent and almost total failure. However, there is a bit of a light at the end of that tunnel in that you can supplement lifestyle and nutritional measures with a new family of drugs which appear to be effective and safe. This is an example, semaglutide, the so-called GLP-1 agonists. And this graph shows that over a 4-year period, a group of people who came into the study weighing about 100 kilograms could drop 10% or more of their body weight and keep it off for 4 years continuously. And that also corresponded with a reduction in heart attack rate and stroke rates. So it actually is not only possible, it turns out it's actually worth doing. It's the first time that's been proven. So we don't have ready access to that class of drugs right now in New Zealand. There is some, particularly for diabetic people, but it will be coming. So it's something to keep in mind if you struggle with this. The Christchurch Heart Institute looks at a lot of people who are still healthy on the left-hand side of the slide, those that have got their coronary disease, and those on the right-hand side that are advanced to the point where their heart is quite badly damaged. And what we do is try to refine that risk estimation that Ben told you about. So I showed you a slide earlier and we defined a man at 45 who had about a 5% risk. Now, it'd be nice to know not just that you're one of the 100, and somewhere in that 100 there are 5 people who are going to be unlucky. It's really nice to know whether you're one of the 5 or not, wouldn't it? That would be very useful. So a lot of our research is aimed at refining risk stratification, at being more accurate at identifying who is in trouble and who is safer. And we do that partly through identifying blood tests. One of our blood tests is called NT-proBNP, and what we've found is that you can add that test on top of all the things I've mentioned, blood pressure, cholesterol, etc., and you can refine a degree of risk. So the top line there shows the top levels of NT-proBNP, and compared with the lowermost levels, the risk is increased by about 10-fold, even though these people look pretty much the same if you just saw them walking in the street. What about those pesky unknown things that account for that 15% of heart attacks that we cannot really understand why they occurred in the first place? Well, some of those are going to be hidden away in our genes that produce proteins that are slightly abnormal and make your blood vessels more inclined to narrow and then later possibly clot. So this is a work in progress. Those are chromosomes lined up. We've all got a fair number of those, and the genes sit on the chromosomes. In 2006, there were about a handful of positions right across the entire genome, all of the chromosomes together, that looked as though they could be associated with the risk of heart attacks if they were slightly different from the usual standard gene sequence. So that's not much to go on, but this, as I say, is a work in progress, and as the years have ticked by, there's been a lot of progress in this area so that we now have over 2,000 candidate points in our genes that may be partly responsible in some people for why they get a heart attack. And every one of those dots you can see on that slide represents an opportunity. It represents increased understanding at one level and possibly a protein target to diminish or increase, to reduce or someone's risk. The other part of our toolkit, aside from markers in blood and genes, is images, or the way the heart looks. This is ultrasound, so the upper image there is a healthy heart moving very well and symmetrically. The lower one is far too big and scarcely moving at all. And so what we do at CHI is we try to use this toolkit of markers, genes, and pictures of the heart to predict, explain, prevent, and sometimes even reverse heart damage. We can see where narrowings in the arteries are, and we can also take a look with special scans at the heart. That central chamber there is the interior of the left ventricle, the major pumping chamber. It has a thick wall around it. The arrows are pointing to a part of the thick wall that looks a bit different on that initial scan. And you can use tracers that show which parts of the heart are actually metabolizing, which cells are alive and functioning well, and which are not. And you can see the arrows are now defining a rather non-functional area. So we have a wide toolkit, and we're making steady progress as time goes by. My last couple of slides, what happens if you do have a heart attack? What are the prospects if you do have one? Well, help is on the way. In Christchurch, it should be possible to reach within the main perimeter of the city anywhere within 7 minutes of a call, but you do have to call. So you've probably seen the ads on the TV of the chap who takes a shower instead of calling, and someone who takes a walk instead of calling. Don't do that. We cannot help you if you don't turn up. And sometimes you'll turn up and it'll be unnecessary, but we'd much rather it was that way around. If you do get in and you've got a blocked artery, the chances of opening it with angiography and putting a stent in to prop it open are very high, and that will diminish damage and improve your prospects. Once that's done, other things are always improving as well. Our ability to lower cholesterol is getting better and better and better, with less and less side effect problems. Our ability to control people's blood pressure is getting better and better. Our ability to manage clot is also getting better. So the range of drugs other than rat poison that we used to be stuck with for a long time is actually vastly better and vastly safer than it used to be. You can have devices put in, pacemakers that keep things ticking at the right rate, shock devices that can actually defibrillate you from inside if you need it, pumps that can actually augment your own pump, and in the most desperate situation, ECMO, extracorporeal membrane oxygenation, can take over the entire function of your heart and lung temporarily while your body is giving a chance to recover from whatever crisis has led to that state. Then there are more standard measures. Coronary artery bypass graft surgery is actually one of the most frequent surgeries done in the world now. Valve surgery, valves can be repaired and replaced, both by catheter and through the chest. And if all else fails, with a bit of luck, we might be able to get you a new heart. That's a hard trick to do, but we do it. And it so happens that in New Zealand and Australia, survival rates after heart transplant still rank in the best in the world. However, it would really be best to avoid all of that. And taking attention to your weight, your exercise, your cigarettes, and your cholesterol will actually help you stay away from us, which is what you really want to do. So I'd like to acknowledge our funders and our thousands of patients, and thank you for listening. I think that might be you next.
That's amazing. Thank you very much, Mike. I know you've given your microphone away. I'll come over to you. What is around? What's next? What's going to be the big thing that's going to save more lives in 5-10 years' time, say? Maybe more.
Just about everything is getting better all the time, but it's also getting more expensive. And the problem is inequality of access for a whole bunch of reasons. But to give you one example, there's a kind of cholesterol called Lp(a) that's not attacked by our standard drugs. Statins are pretty good. Lp(a) is lurked in the background, and about 15 to 20% of people who have coronary events have this elevation of this rather special kind of cholesterol. We've never been able to treat it. But recently, we've learned how to manipulate genes to make people turn off their own manufacture of that drug. And that's a trial that's going on. It's called gene editing. It's actually going on in Christchurch at the present time, the only place in New Zealand where it's happening. And I predict that that kind of approach will be able to tailor very specific, powerful therapies for people, and that will burgeon over the next 5-10 years and beyond.
That sounds amazing. Thank you very much. Right. What's that, sorry? This one's up. All right. Okay, well, carrying on. Dr. Michael Hlavac. Michael gained his medical degree from the University of Otago in 1993 and he was made a Fellow of the Royal College of Physicians in 2002. He specialised as a respiratory and a sleep physician, completing his advanced training in respiratory medicine at the Christchurch Hospital here, before travelling to Australia to gain experience in sleep medicine. As well as being a working consultant for Te Whara Ora Waitaha Canterbury in the public health system, Michael's a private consultant at CanSleep here in Christchurch, which provides diagnosis and treatment specifically in sleep medicine. As well as clinical assessment, they also carry out sleep studies, therapy and long-term follow-up for people with sleep issues. It's also a growing area of medicine, with research now making it clear there's an extremely strong link between sleep, or lack of it, and not just our energy levels and mental sharpness and acuity, but also hormones which are linked to obesity, muscle repair, dementia, risk-taking behaviour, depression, and also arming the body's immune system to fight disease. And if anyone here sleeps next to a snorer, Michael, can you help?
Thank you, Lorelei. Thank you for that introduction, and thank you for inviting me to speak tonight. Yes, there is such a thing as a sleep specialist, and it's a real thing. And yes, I am also a doctor as well, as a disclaimer. So, but I do specialise in sleep medicine, and I guess the thing which drew me towards an interest in this is the fact that sleep is one of those things that's ubiquitous. We all sleep, and we all expect to sleep well. We run into problems when we don't sleep well. And one of the themes tonight was myths and truths, and what I was hoping to do is to talk through a little bit of the myths and truths that are relatively common around sleep, and then talk a little bit about some of the more common sleep disorders, and particularly just touch a little bit on obstructive sleep apnea. Why do we sleep? A good question. We don't really know, and in fact, the quote that I put up here is from a guy called Bill Dement. Bill Dement is considered the father of modern sleep medicine. He discovered REM sleep. He wrote the 900-page textbook that's sitting in my office, and his answer was, as far as we know, it's just because we get sleepy. So there wasn't really a scientific answer given to that. But what we do know is that sleep is really essential for all animal species and for all of our normal bodily functions. All animals that have a brain will sleep, and some animals with very small brains, bees, nematodes, probably sleep as well, as far as we can tell. If you deprive people of sleep, they have a much longer sleep to catch up. Clearly, we need a balance of sleep. And if we restrict our sleep, there are very immediate and very significant impairments in brain function. So clearly, our brain requires sleep to function normally. A really good example of that is in dolphins, who sleep with one half of their brain at a time, so they can remain awake and they can still swim around and not drown, but they're also getting the restoration and benefits of sleep, and they alternate from one side to the other. And lots of other aquatic mammals do that as well. The theories that we have are that sleep is a way of avoiding harm. It gets us away from predators at night and when we're not alert. It's really important for brain growth and development in kids. The brain requires sleep to develop new skills and for wiring to become established. Brain function is really important, energy conservation. And we know that most body systems have a body clock. So you have a system that rotates around the clock through day and night, and that's very much tied in with our sleep. And if we don't sleep well or we sleep at the wrong time, our body clock gets deranged, and then issues with our immune system, muscle strength, normal physiological functioning, all of those things deteriorate. And eventually, if we don't sleep for prolonged periods of time, we fall ill, our immune system doesn't work, and eventually we die. And so sleep is fundamental. It's one of those things that we cannot live without. This is an example of what normal sleep should look like. And I really put this up, not that I want to answer questions. Sorry. Just hear that. I'm not putting this up because there's going to be a quiz at the end and I want you to recall all the different sleep stages, but really to just show you that there's a structure to our sleep. It's not just a single block of the same thing. Sleep is quite variable. We start off awake, we go very rapidly through light stages of sleep, and then we go into stage 3, 4, or deep sleep. That's the sleep that it's really hard to wake from. It's a sleep that if you're woken from, you might not remember having been woken. And if you have a nap in the afternoon and sleep for more than about half an hour, you'll go into deep sleep and you'll feel terrible when you wake up and you get this sleep inertia. That all happens in the first half of the night. It's really important. We go through a little bit more of that, and then we have these periods of REM sleep or dreaming sleep where we dream, where muscles are relaxed, And actually REM sleep's really light, it's broken, we wake up from dreams, we go back into dreams. And REM sleep is one of those things that we see a lot of later on in the night. And REM's one of the things that we lose with sleep disorders, particularly with things like sleep apnea. But the point is that it's really normal to wake. No one sleeps right through without waking. It's very abnormal to do that. So some people will overestimate how much they're awake, or they'll assume that they shouldn't wake at night, but it's actually a normal part of the way that our brains sleep. This is an example of our sleep duration, and people always say, Dr. Hlavac, how much sleep should I get? I hear it's 8 hours. What do you think? And it's actually really variable, and it varies across age and time, and it varies from person to person. So some people are long sleepers, other people are short sleepers. We have our own body clock, and that body clock dictates how much sleep we need. The point I'd like to make with this is that kids need lots of sleep, teenagers and adolescents. Once you hit young adulthood, pretty much from then on for the rest of your life, you need about 8 hours sleep a night, between 7 and 9. And I guess the point here is that as you get older, you just expect not to sleep as well. You expect your sleep to be more broken. You expect that you're not going to get as much sleep. That's actually not true. And if you're not sleeping as well, or you're not getting as much sleep, it may be because you have a sleep disorder and not simply because aging confers a worse sleep quality. That's not the case. And this leads into some common myths about sleep and things that we often try and debunk when we're seeing people and we're telling them about their sleep habits. You can't train yourself to get more sleep. To get less sleep. There's this great story of Winston Churchill who said he only slept for 4 or 5 hours a night and that's all he needed, and he probably was just a short sleeper and got by on that. If you try and train yourself to get less sleep than your body clock requires, you'll just get tired and then you won't function very well. So that doesn't tend to work. But conversely, you can't bank sleep in advance is the other thing. So if you have long periods of sleep, it's not like you can then have a weekend where you only spend 3 hours of sleep every night. The body doesn't work that way. You need the same amount of sleep consistently, and having long sleeps doesn't protect you against being sleep deprived. You can't decrease tiredness by spending more time in bed. If you lie in bed awake and you're not sleeping, you're not going to get less tired. In fact, the opposite's true. There's this thing called sleep inertia, where people that have long periods of time in bed or long periods of trying to sleep, they become more tired. They seem to develop more of a habit of inertia, and it causes physical tiredness and increase in sleepiness. So prolonged bed periods are actually counterproductive. I don't think it's wise to avoid daytime napping if you're tired. And there's good evidence that having short naps during the day, 20 minutes and no more than that, is really helpful to restore you if you've been sleep restricted on previous nights or if you're tired. Our body clock says that we will get sleepy in the sort of early to middle part of the afternoon, like siesta time in the Mediterranean. That's your body's way of telling you that a sleep is a good thing to have. We don't always have the opportunity to do that, but short sleeps, like 20 minutes, really help to restore you and improve brain function. Any longer than that, and you get into that deep sleep I mentioned earlier, and then it's much harder to wake up, and it will affect the way you sleep the following night. So short naps are a good thing. Alcohol cannot help you sleep better. Alcohol may help you to fall asleep at the very beginning of the night. It's a neurocognitive depressant, but your sleep quality is impaired and is much worse. It's more broken. It then leads to other sleep disorders. You're up for a pee 2 or 3 times overnight. Alcohol generally is counterproductive to sleep quality. And as I said earlier, you should not expect your sleep to get worse as you get older. If it's getting worse, there may well be some other problem, and maybe having your sleep assessed formally is the right thing to do, rather than just at expectation. These are my 10 tips for good sleep hygiene, things to remember. And they're really straightforward and they're fairly self-evident, and probably don't need me to tell you most of these things. Caffeine's a stimulant. If you have it within 4 hours of bed, it will probably delay falling asleep. Nicotine likewise is a stimulant. I'm a respiratory physician as well. None of my patients should be using nicotine at all anyway, but if they're going to smoke, they should do it earlier in the day. And likewise with alcohol. Large meals tend to delay sleep onset. Exercise is good, but not just before you go to bed. You're still very stimulated and it takes time to relax. Make sure that your sleep environment is, I said good, clean sleep environment. It's tidy and it's orderly and it's calm and it's quiet and there's dim lighting and it's warm and all those things that you need to get a good night's sleep. And I've kind of covered some of those other things. The bedroom really should be for sleeping, not TV or social media or eating or gaming or other things that people do in bed. We know that those sorts of activities in bed or at bedtime, they shine light into your eyes, which tell your brain it's time to wake up. They stimulate the brain, and they will delay sleep onset as well. And so that last hour before sleep, before getting into bed and turning out the lights, is a time of preparation for sleep, relaxation, and trying to set the brain up for that. The other thing is that we rely upon routine. Our brains love routine. We love waking at the same time, going to bed at the same time. That's our body clock. That's how we tell our body clock how it works. And if we disrupt that routine, our brain doesn't know what to do. And if you stay up late, your brain then suddenly thinks, well, I should be staying up late every night, and it gets harder to fall asleep at night. And if you sleep in the morning, like my teenage kids have been doing for about the last 10 years, that becomes the norm. And then they'll go to bed later, and they'll wake up later, and your whole body clock can shift. So trying to establish routine is really key for good sleeping. I'm just going to finish by talking a little bit about obstructive sleep apnea, which is the most common serious sleep disorder. Some studies estimate that half the adult population have sleep apnea, so it's really common. In essence, without kind of sciencing it up too much, it's recurrent partial or complete blockage of the throat during sleep. That narrowing leads to a drop in oxygen. It leads to a stoppage or pause of breathing, which is called an apnea. That then in turn leads to arousal from sleep, broken and disrupted sleep, and daytime consequences, which include tiredness and poor brain function. There's a spectrum of disease. I've got a question for the men in the audience. How many of you snore? Show of hands, please. How many of you snore? Okay, bed partners of the men who are here with them. How many of your husbands or partners snore? Okay, pretty good actually. Usually the ratio is very much weighted in favour of the partners rather than the sufferers. Because snoring is one of those things that men don't like to talk about. It's embarrassing. It's a sign of weakness. They don't consider it's a problem because pretty much most of the time you don't hear yourself snoring. So often when I see patients who snore with sleep apnea, it's the bed partners who have encouraged them to come along, somewhat reluctantly. Why are you here? I'm here because she tells me I snore. Do you think you've got a problem? No, it's her problem. But these are couples who now spend nights in different rooms. Or the snoring is so loud on one side of the bed that the bed partner's going deaf with high-tone hearing loss on that right ear that faces where the snorer is. I've seen that twice now. So snoring can be important, but snoring's key because snoring is a key feature of sleep apnea. The main risk factors for sleep apnea are being a man, being middle-aged, carrying extra weight, having a family history of sleep apnea, even if you're not overweight. If there's a genetic history, it means your airway is probably narrow. And things you can do to avoid, like alcohol and smoking. It's very similar to the risk factors that Mark's already told us about. Here are some of the symptoms. Loud snoring, yep, we've touched on that. Witnessed apneas, where there are breathing pauses. Your bed partner says, look, he snores really loudly, and then he just goes quiet for like half a minute, and I think he's dead, and shake him, and he starts breathing again. And he starts snoring again, and I go, I wish he'd stop breathing again, and just kind of goes on and on. But that's the sort of history we get. Sufferers of sleep apnea often don't know this. They might wake up choking or gasping or feeling that their throat's blocked up, not always. Often they might just say their sleep is restless. They get up to pee a lot. Peeing 3 or 4 times a night is often a feature of sleep apnea. And then in the day they get all these things. Wake up with a headache, like I'm hungover but I haven't had alcohol like for 10 years. Why do I feel so terrible in the morning? Very tired, poor concentration. And obviously these last 2 things down here about sleepiness and concerns around routine activities, that's particularly important if you're an occupational driver or if your occupation involves machinery or a skill saw or you're a butcher or some of those things where there's risk if you lose attention. Occupational risk is really key with some of these sleep conditions. Sleep apnea is not just a problem causing sleepiness, and we now know that it's a risk factor for a whole range of comorbidities and disorders. Cardiovascular disease, hypertension, stroke, they're much higher in people with untreated severe sleep apnea compared to those that don't have it, or people who've got sleep apnea but it's treated. Erectile dysfunction, really common cause of sleep apnea. Depression, anxiety, heart disease, obesity. Obesity is great. It causes sleep apnea, and sleep apnea causes obesity through changes in hormone regulation. So it sort of perpetuates itself and makes itself worse. So this is a systemic problem. It's not just a single brain function, it's the whole body being affected by sleep apnea. Which comes on to treatment. Unfortunately, treatment of sleep apnea is accessible. It's not ideal. Disclaimer, some of the stuff we use, CPAP machines, they're not brilliant, but they work really well for those people with significant symptomatic sleep apnea. And there's this myth that you put on a CPAP machine, you look like Darth Vader, nobody wants to talk to you or sleep with you. It's certainly quieter than snoring, and it's certainly more attractive to your partner than sleeping in a different room because of the snoring. So there are ways that we can improve people's sleep apnea. Management, often lifestyle factors. We've already heard about weight loss and exercise, and we know that if you can lose 10% of your body weight, you'll probably drop sleep apnea severity by about a third. If you exercise, and we're talking about cardiovascular exercise, you'll reduce sleep apnea severity, even if your weight doesn't change. So just getting fit will help to reduce breathing pauses at night. The hospital system uses CPAP. If you're referred into us and you're diagnosed with sleep apnea, you'll be offered a trial of a CPAP machine if you're severe enough. There's a whole range of devices. They're not noisy. They're much quieter than they used to be. The masks are really comfortable. These are much better than the technology we had 10 or 15 years ago. And basically, CPAP works just by providing air pressure to the throat to hold it open, to stop those breathing pauses, to stop snoring, and to restore some of that normal brain function that you get when you have sleep apnea. We also refer people for a thing called a mandibular splint, and this is a dental device made by a dentist or an orthodontist. You wear it in your mouth, it attaches to your teeth, it moves your jaw forward slowly and gradually over time, and that improves airflow and reduces snoring and can reduce sleep apnea almost as well as a CPAP machine can now. So it's quite equivalent to that. Surgery has a role, but really a limited role, and there was a lot of surgery done 10 or 20 years ago for people with sleep apnea who probably didn't need it, or maybe weren't selected as the right group. The people that we refer are kids or teenagers with big tonsils, and anyone that I see with sleep apnea, we check tonsil size because it's a really important cause of sleep apnea in young people. And weight loss surgery. And the advent of these weight loss drugs we're hearing about may well supplant weight loss surgery, but at the moment, if you can access it, weight loss surgery is a really good way of modifying a whole bunch of things, but also obstructive sleep apnea. Local resources, so you can see a sleep specialist, and your sleep specialist closest to you is your GP. We've got a really good group of GPs in Christchurch. They've all been to our sleep education sessions. They're all tied in with our community sleep assessment pathway. So if you go to your GP and say, I think I've got sleep apnea, your GP will refer you for a fully funded home assessment. It's a home monitor that you wear in your own bed at night, just for one night, that detects severe sleep apnea. Doesn't cost you anything, and then those results get put through, and people with severe sleep apnea come through the hospital system. If you're really severe, or you've got an occupation where you're at risk, or you've got significant health issues, you may qualify for hospital-funded CPAP therapy, which is provided through the Te Whatu Ora. There are some private sleep providers. I'm one of them. I'm not the only one. There's a lot of people doing sleep medicine. There are also dentists that provide care for sleep apnea with those devices I've shown you. Here's a couple of websites. Health Info is a patient website. You can go log into that. There's a whole series of pages on not just sleep apnea, but insomnia and other sleep conditions. Sleep Health Foundation is just a good website for information about sleep disorders in general. And that bottom one is for those people with insomnia, which I haven't talked about, but it's a good resource for managing insomnia. I would direct you to those things if you've got concerns about your sleep. Thank you.
So those things, when you go on Instagram, you click on something and you just get again and again your algorithm. All those little devices for your nose, those clips, waste of time and money?
Pretty much, yeah. I mean, it sounds a bit cliched, but the more you spend, the more likely you are to get something that works. So the mouth guards that I've showed you, you can get a boil and bite one from Harvey Norman. You stick it in a jug of boiling water and put it in your mouth. It's about as good as a rugby mouth guard, so not great. The ones that are made by a dentist or are fitted, they're much better. Taping your mouth shut, my dad did that for about 10 years. I told him not to tell anybody that you tape your mouth shut because your son's a sleep specialist and we don't recommend doing that. Nose clips don't tend to do a lot. I mean, most of those things are of limited benefit. And if you've got significant sleep apnea, you really need to get it properly assessed. Yeah.
Good advice. That's wonderful. Thanks so much again, Michael. Right, our last speaker, Associate Professor Katie Douglas. Katie gained both her Bachelor of Science Honours and her PhD here at the University of Otago. She's a Research Associate Professor in our campus's Department of Psychological Medicine, and she's a registered clinical psychologist. Katie's been awarded 7 major research grants as Principal Investigator, including the prestigious Sir Charles Hurkis Fellowship from the Health Research Council of New Zealand in 2018. She's currently leading an innovative trial of group-based cognitive remediation in mood disorders. She has an interest in research in behavioural activation therapy, BAT. It's a treatment commonly used to help people with depression, but Katie's researching whether it could be effective in treating bipolar disorder. Her other research interests focus on the impacts of earthquake-related PTSD and the influence of childhood trauma on mental health. Katie's Deputy Chair of the Australasian Society of Bipolar and Depressive Disorders, and she supervises several PhD students here in the areas of cognitive functioning and mood and anxiety disorders. Welcome, Katie.
Kia ora koutou. I'm starting off with a little bit of audience participation just to make sure everyone's still alert for the last talk of the evening. So when thinking about men's health and particularly mental health in midlife, what do you think this sports car might represent? Shout out if you have any.
Midlife crisis.
Bingo. He's not my brother-in-law who I told the answer to, by the way. How about these marbles? Oh, yeah, you're onto it. Losing your marbles. So, as Laura Lee said, I'm a clinical psychologist and a mental health researcher over the road at the Department of Psychological Medicine. And tonight I'm hoping to bust some myths and provide some truths about men's mental health in midlife. And I'm going to be weaving these metaphors into the talk. So first of all, the phenomenon of a midlife crisis. I feel like Laura Lee actually covered quite a lot of this content in her introduction at the start. But I'm sure all of you have heard of the term tossed around in your social circles. Perhaps one of your male friends has impulsively bought a car or an e-mountain bike, and perhaps that's a sign that this person's going through a midlife crisis. But is it actually a thing? And so I'm going to spend a little bit of time just kind of fleshing out what a midlife crisis is. There's lots of variable definitions on Dr. Google, but essentially what a midlife crisis is a period of emotional turmoil with sudden changes in personal goals and lifestyle that occurs in midlife. Fleshing it out a bit more, when we talk about midlife, it's a pretty broad age range, somewhere usually from about 40 to 60 years old. It's the period of time that's sandwiched between young adulthood and old age. But in terms of midlife crisis literature, essentially it's referring to a kind of a group of transitions that are difficult for men in their midlife. So this might be things like divorce, an empty nest syndrome, losing your parents or losing your job. But we also know that there's lots of other stressful transitions across your life, and perhaps there's not really, the stresses in midlife might not be particularly more than in other periods of your life. We also know that actually plenty of men go through midlife period quite positively. It can be a time where you're making positive changes and reprioritising based on these transitions. So it's by no means inevitable that everyone is going to go through a midlife crisis. And actually research suggests that in midlife about 10% of men will actually go through these midlife transitions in a crisis-like way. There also seems to be this thought that it's restricted to men. It's often men who are kind of identified as having a midlife crisis. So if a man seems to be struggling with mental health problems in midlife, it's put down to a midlife crisis. Whereas if women are struggling with mental health in midlife, it seems to be put down to menopause or other things. But there are actually danger in these assumptions, which I'll come to soon. What we do know definitely about a midlife crisis is that it's not actually a mental health disorder. So it's not in our diagnostic manual of mental health disorders. What is in this manual is major depressive disorder or depression, which has some overlapping features. So major depressive disorder or depression is often called the common cold of mental health disorders because it's so common. It affects 1 in 6 New Zealanders and 1 in 8 men at some point in their life. And essentially, to get a diagnosis of depression, you need to have at least 5 of these symptoms in the picture here. So you have to have a depressed mood and inability to feel pleasure, or sometimes known as anhedonia. There's also often feelings of worthlessness or excessive guilt, suicidal thinking or plans. There's the fatigue and loss of energy, as well as sleep and appetite changes. And then there's the cognitive symptoms like having trouble concentrating or having problems making decisions. To actually get diagnosed with depression, this also needs to be causing significant impairment. So people are often finding it very hard to hold down a job or function in relationships when you're in the midst of a depressive episode. So men might not actually realise that they're depressed in midlife, or they may not seek help because it's put down to a midlife crisis that's kind of a normal and transient thing that they'll get over with time or after they've bought their fancy car. Laurelie also touched on this, the kind of context of growing up in New Zealand, and I think for people in their midlife at the moment, it's really common that they grew up in a context of kind of not showing signs of vulnerability or weakness, or the saying that I heard a lot when I was growing up was drink a cup of concrete and harden up. And I think that these kind of sayings that are really common in the New Zealand context actually aren't helpful in terms of seeking help if you're really struggling with mental health problems. So this is a graph here that's showing the rates of suicide in New Zealand. What we know is that women are much more likely to have depression than men, but men, as you can see from this graph, are much more likely to commit suicide. So this shows the number of confirmed suicides each year in New Zealand, and you can see in 2019, nearly 500 men committed suicide. So it's a very concerning issue that I'm circling back to Ben's talk now and saying that you need to go to your GP. If you or your loved one is concerned that either you're depressed or you're going through a midlife crisis, it's worth going to see your GP. The gold standard treatment for depression is a combination of antidepressant medication and psychological therapy. And your GP can help with both of those in terms of prescribing medication and also referring to psychological therapy. For antidepressant medication, sometimes it can be a case of trying a few before you find one that fits for you. And in terms of psychological therapy, in terms of the misconceptions about that, it doesn't look like the picture there. I've never had someone lie down in therapy when I've been doing therapy. I have had one person fall asleep who probably had sleep apnea. But I think sometimes there's a hesitation to go to therapy because of the misconceptions from the media of what therapy actually is. It is actually a very systematic, practical, pragmatic treatment. And yes, it's great to be able to open up and show vulnerability and show emotion, but it's tailored to you. So there's every hope if you go for psychological therapy that you'll be able to make short and long-term changes to benefit your mood. So the next, it's not really a misconception, this one's more of a concern that is quite common in midlife for men, and that's, am I losing my marbles? This saying kind of refers to the perception that maybe you feel like your mental functions or your cognitive functions aren't quite what they used to be. And there's a concern that these perceived cognitive problems might actually be the start of something more sinister. Perhaps it's a decline into aging with cognitive impairment or dementia. So perhaps it's feeling like you can't keep up with conversations as well as you used to, or perhaps you're losing things and forgetting things more often, or maybe it's a more pervasive brain fog that you're feeling. So for some people, those cognitive changes might actually be a sign that there's something going on and that you might be in the early stages of cognitive decline. But for many, these cognitive symptoms might actually be related to lifestyle or mental health factors. So just taking a quick step back for some definitions here. When I'm talking about cognitive functions, I'm talking about brain-related functions that we need to be able to complete from the most simple to the most complex tasks in our day-to-day lives. So all of these things here would be classed as cognitive functions. Perhaps it was trying to find a park tonight to make this talk. So you used some spatial ability to get here, and then paying attention in these talks, sustained attention now because we're nearly at an hour. Or perhaps it's actually trying to remember what was said in these talks tomorrow when you talk about it with colleagues or friends. And what we know in terms of the mood disorder or depression literature is that when you're in an episode of depression, these cognitive functions are often very impaired. We often show pretty large differences when we're when we're looking at a depressed sample compared with people without depression. So it's really common for me to hear things like, I have not read a book for 3 years now because I can't concentrate. I can read the same sentence again and again. It used to be something I really enjoyed. So it might not be that you're losing your marbles, it might be actually that these perceived cognitive changes might be the sign of depression or a mental health disorder or something else that I'll come to soon. So these cognitive symptoms in depression are actually a core feature of depression, and they relate really strongly to problems in your day-to-day functioning, such as in your work, in your relationships, in any other kind of chores or daily functions. They're also experienced as really frustrating and concerning for people, often actually rated as more concerning and frustrating than the mood symptoms of depression, like depressed mood. We also know that men are likely to underreport cognitive symptoms, so they have a more stoic profile. So even if they're showing impairment on cognitive tests, they might be less likely to report that they're having cognitive problems. So hopefully I've hammered home the message that depression and cognitive impairment often go hand in hand. There are other things that also relate to cognitive impairment that it's important to think about too. So chronic stress, if you're in a really stressful job that you're working long hours in and you're feeling burnt out, and that has happened over a prolonged period of time, it's likely that actually that is causing some brain changes, and that has an impact on your cognitive functions. Sleep problems we've heard about from Mike, and the impact that that has on your cognitive functions. You'll all know from sleep deprivation, if you've had young kids, that it's pretty hard to feel cognitively sharp the next day. And all of these factors all kind of mix together too. So in terms of improving cognitive functions, I'm repeating some messages here. The top 3 points are things that you can do that should actually help cognitive functions. And I wanted to spend the last few minutes talking about brain training, which is a specific treatment designed to improve cognitive functions. So this is a treatment that has gained some attention, well, a lot of attention in the dementia and Alzheimer's literature in terms of protecting against dementing processes. But it's also been found to be effective for depression and lots of other mental health disorders. And so when I talk about brain training in these types of areas in terms of mental health disorders, I'm talking about regular and repetitive practice on exercises to improve or maintain one's cognitive ability. So we use, in lots of the studies that we use at the department, we use a platform called Happy Neuron. And this is something that can be accessed by anyone. You do have to pay money, but it's a good one. There's lots of other free apps like Elevate and Lumosity that are similar, but I think I would recommend Happy Neuron as the first port of call because it's designed with science in mind. So that's something that you can do in terms of brain training exercises. And essentially that's just like going to the gym for a physical workout. You're wanting to keep training your brain to maintain cognitive health. There's other things you can do outside of computerized exercises too, if you're not really a computer person. So you can actually set up your life so you're still cognitively challenging yourself. Things like training your memory by not taking your shopping list to the supermarket and trying to remember all the items, which there's some funny looks in the audience for that. You could just have the list in the back pocket in case you're hosting a dinner party that night or something. One that I do, because I'm particularly poor on spatial memory, is I try and do brain training exercises by not relying on Google Maps and trying to get places without getting too lost or taking new routes to get to places. There's a teacher at my kids' school who has this seemingly amazing ability to remember every kid's name in the school as well as all the family members, and he also welcomes every kid at the morning at the school crossing in their native language. And being the research geek that I am, I had to go and ask him what he was doing, and I kind of thought he's going to just say he's got some photographic memory, but actually he is just constantly training himself. He was saying that he just walks around the playground every day kind of trying to memorize kids' names, so he's repeating it and he's using all sorts of different memory strategies to make sure he remembers everyone's names, and that's very helpful for his job as a teacher. There's also sorts of other things you can do, learning new skills, learning languages or musical instruments. All of these things are really helpful in terms of maintaining brain function. So that's it.